Thank you, Dr. Padma. To start off, I do not have any financial disclosures. As we all know from the previous instruction courses and through the day, that uveitis comprises of diverse diseases which range in severity. And if this is untreated, it is an important cause of permanent visual loss and has a huge socio-economic impact. So the treatment we have is a range varying from topical medications to aggressive systemic immune suppression, again depending on the type of uveitis we are dealing with. But what is interesting is, unlike before, the future holds a lot of promise, especially there are many therapies which are in the pipeline. So as we all know, corticosteroids still remains and will remain the mainstay of therapy in uveitis, and only the form in which it is being given is changing day by day. Again, it can vary from local therapies to systemic therapies. So we are all familiar with this range of medications which we use to treat our patients with anterior uveitis. So what's new in topical steroids is this new steroid called difluprednate. Again, this has been there in the market for quite some time now, and this has been marketed in India as these brands. How is it different from the conventional steroid? It is a difluorinated prednisolone derivative, but what is important is it has a greater receptor binding activity, so therefore the effect is much better, and the corneal penetration is much more, and that's the reason why it is given at a lesser dosage. So these are additional features which are there in this particular drug. From the studies, when we review the literature, again, it has a consistent dose uniformity, especially when it is compared to other topical prednisolone, topical steroids, especially the prednisolone acetate group. And 4 times dosage is as good as what you're giving 8 times of prednisolone acetate. So these are landmark papers which have come up, which show a good promise in this particular molecule. However, the safety, like all corticosteroids, is still a concern, and we have patients who have had increased intraocular pressures even while they are on difluprednate. So this is something which we still need to keep in mind even when we are dealing with this new molecule. Again, these are multiple papers which have come out on increase in intraocular pressure, especially in pediatric group of patients. So from a general ophthalmologist's point of view, is it good or better than prednisolone acetate eye drops? This is something which we need to see because we are treating our patients. Now, what is important is when we look at the literature, most of the studies which have been done are from the international brand, that is the Durezol by the Alcon. So we do not have anything which we can compare with the Indian brands which are available. However, whatever results are available, they show it has a better compliance, probably because of the decreased frequency which we are using. Increased potency because it has a better penetration, better bioavailability, and consistent dose uniformity. And there are studies which show that this has a limited systemic absorption and has a rapid local metabolism, which it shows that the adverse events when compared to the other steroids are definitely much lesser. Now, what is the next which is in the pipeline, which is what we call as iontophoresis. So what is iontophoresis? This is more used in the skin-related diseases. Now, iontophoresis is you apply low current to an ionizable substance, and this increases its mobility across the surface by what is called electrochemical repulsion. And the studies which have been done, that is the EGP437, has been done on patients with anterior uveitis, where they have used this drug called dexamethasone phosphate. These studies were conducted in India, and what we have had so far is a phase 2B study. And it has found that this is quite a safe and an effective way of doing it. Again, we are awaiting the phase 3 studies. So this is how the system is, and you apply the electrode. One of the electrode is to the like a contact lens, and you apply it on the eye, and the other one is connected to the generator, and this is how it is. And so this is one which goes on the eye, and this is the generator which gives the current. And this is how it is done, and these molecules enter through the cornea and predominantly into the anterior chamber. And in the study which was used, these were the dosages which were given over 4 minutes. Now, now there are also trials which are going on in the previous months, so it has still not been marketed. Now, we are all familiar with the periocular injections like the posterior subtenons. We give intravitreal tricot injections, and we also give oral steroids and intravenous methylprednisolone, again depending on the grade of uveitis, especially if they are intermediate, posterior, or pan, or vision threatening. The range of systemic medications are also used. All of us are still familiar with this picture from Davidson, which shows the complications of oral steroids, which if given over a period of time. So what is important is now the onset of local. Now is the era of local therapy, and one of the injections which are available are these intravitreal steroid injections. And the drug which is now commercially being used is what we call as the Ozurdex. Now, this is a bioerodible implant, and it contains 0.7 milligrams of dexamethasone. The effect usually lasts for 3 to 4 months, and it has been documented in the studies that there is an improvement in vision and there is a decrease in cystoid macular edema. However, you still have the side effects. 25% had increase in intraocular pressure. Again, this is a little lesser compared to the earlier implants. And these are the other reported side effects. But this is a medium-acting intravitreal steroid. More importantly, it's an office-based non-surgery procedure, and it is less expensive than the earlier implant, which is the Retisert. And this is available in India for our use. And fortunately, the companies have reduced the price for us, and it is becoming more commonly used these days. Now, this was the older implant, which is the Fluocinolone acetonide implant, and unlike the Ozurdex, this is a non-degradable implant, and it contains 0.59 milligrams of Fluocinolone acetonide. The advantage is it lasts for a longer period of time, but longer it lasts, the more complications. So definitely the IOP, the glaucoma was a concern with this particular implant, and nearly 1/3 of the patients required glaucoma surgery, and nearly all patients required cataract surgery. However, this is pretty expensive, and initially it was used in India as a part of the trial, but we still haven't seen this in in India commercially. Now, this is one of the patients with Ozurdex, and if you see the drastic reduction in the response in the cystoid macular edema, and therefore this drug does hold a lot of promise because the steroid is delivered inside the eye at the site of inflammation. So basically, why do we look at intravitreal steroids? Whichever steroid you use, they are mainly given if the patient has been having a lot of systemic complications. So you're trying to use something to reduce the systemic complications. Sometimes the patient are already on so much of drugs, and this adds, and it gives a good inflammation control with adequate dosage of immunosuppressants. And many times, if the patient is planning a pregnancy or conceiving, they seek a brief period of no inflammation, you do consider local steroid delivery. But when you look at this MUST trial, or the multicentric uveitis study trial, it looked at patients with systemic control of inflammation as well as local therapies, and they found comparable visual acuity outcomes. But with the Fluocinolone implant, there was, of course, the complication rates were a little on the higher side. But when you look at the systemic immune suppression, and if you're giving them local therapies over a period of time, I think they looked over 2 years, definitely the visual acuity is comparable in both the groups. Now, any steroid comes with a whole set of adverse events. For example, this is a patient who had received tricot, intravitreal tricots for an inflammation, and these are the tricot deposits. And unfortunately, this patient had a very intractable glaucoma and even required a filtering surgery. So this is one of the most important adverse events, that's glaucoma, especially when you're looking at intravitreal steroids. So there were other steroid implants, which some have been used in the past, some are in the pipeline, and these are for completion state. That is the Pseudodex implant, which you place it in the anterior chamber, but lasts for only 7 days. The Illuvian, which is similar to the earlier one, the Fluocinolone, but the release is much slower. And this is also, that was a surgical procedure. Now they're coming up with an injector-like system. And this is the Iontophoresis implant, where they are using triamcinolone, which is going to release the drug over a period of 1 year. Again, these are all in the pipeline. Now, when it doesn't settle with the steroids or they have a lot of side effects because of the steroid, the next drug which we turn to is immunosuppression. And when we look, there was an instruction course earlier before our session on immunosuppressives in uveitis, which covered a whole lot of immunosuppression, varying from methotrexate to cyclophosphamide, depending on the type of uveitis. But what's new? Again, just like we are injecting everything into the eye, the immunosuppressants are also being injected inside the eye. And this is the first ones, the methotrexate, which has been injected in the eye. Now, this has been used earlier for intraocular lymphomas. And this is, again, another drug where you give repeated injections, 400 micrograms in 0.1 ml, but it has to be repeated. Now, this is another drug, sirolimus. They have just concluded the trials recently, and they did present their data recently. And this is sirolimus, which is also being used in non-infectious posterior and panuveitis. The results are still to come out in publication. And this is one of those patients where you have the drug deposit in the vitreous cavity, and once the drug leaves, you have these kind of oil globules which are there in the posterior segment. And this is one of those patients with, just after the injection, within about 2 weeks, a reduction in the vitreous haze. Dr. Sudarshan earlier had mentioned the cytokines and how everything is improving because we are understanding the disease better. We are able to get to the molecular level of the disease and what is causing the problem. So now the aim is to the targeted approach to these particular cytokines. And voclosporin was one of the drugs which had come into trial about 3 years ago. And this was a calcineurin inhibitor, which is similar to the cyclosporin group of drugs. And this was shown to be more potent and less toxic than cyclosporin. And the recent era of biologics, our rheumatology colleagues are now using it quite frequently. And we are also started using in our patients with uveitis. And these are the common biologics which are being used in uveitis. And Dr. Jain had in the earlier instruction course mentioned that adalimumab and golimumab are now available in India. Till recently, that was not available in India. And now they have started using in many patients with Behçet's these drugs. Now, tocilizumab and interferon are mainly for Behçet's, and this is one drug which I think we've started using in our patients with uveitis as well. And this acts against the CD20, and they have shown to have a good benefit in patients with rheumatoid arthritis, vagus, and even methotrexate-resistant sarcoidosis. This is one of the articles which I just seen by Dr. Van Gelder, who showed the stofasitamab in methotrexate-resistant rheumatoid arthritis. All these names are so complicated that you're not even able to pronounce it correctly. Again, if you look at the clinical trials website, these are the different trials which are available. And just a couple of slides. And now we are using Avastin as well for uveitis, especially in tubercular choroidal granulomas. They are known to have VEGF receptors. So if they are not responding to your anti-TB and oral steroids, they even inject Avastin. This is one of those patients which was a vascularized tubercular choroidal granuloma. So to conclude, we are having, as we understand the disease better, we have new targets. Molecular research has advanced, and we are now trying targeted drug delivery. Our main thing is the cost, and it is important to get down the cost if it has to benefit our patients with uveitis. And ultimately, for any uveitis specialist, the ultimate goal is drug-free remission. Thank you very much.